So Center for Youth Wellness is a pediatric organization. We are based in San Francisco. We're focused on early childhood adversity and addressing adverse childhood experiences, otherwise known as ACEs, in pediatrics. We're excited to work with all of you to improve care for patients and families affected by ACEs and toxic stress, and work to transform how the field of pediatrics addresses the issue. So we'll talk about briefly how adversity plays a role in the child's life and how they can be resilient to it. Being able to predictably and compassionately be available for children will help their resiliency. And using this formal screening tool will support and evaluate how best to do this practice. So for the rest of the section, I'm going to go ahead and just remain off camera. Okay, so for CMEs, I was asked to have everybody in attendance to just go ahead and register. The calendar included a link, and I also sent that to Margie. So if you haven't done so already, it's really important to please register for this. And here on this screen, you'll show how many credits folks will get that are applied to it. So for medical professionals, it is about a 1.25, and other professionals, 0.1 continuing education units, representing 1.25 contact hours. So formally, my name is Mernell Gomez. I am the Training and Technical Assistance Manager here at NPPC at Center for Youth Wellness. And I am joined today with Lena. Did you want to introduce yourself?
Hi, everybody. This is Lena Singh. Nice to see some familiar faces again from when we were there in June. I'm the Program Director for the National Pediatric Practice Community at the Center for Youth Wellness.
Great. Carissa? Carissa, I think you're on mute. Uh-oh.
There we go. I couldn't hit unmute fast enough.
Okay.
Good morning, everyone.
Good morning.
I'm very thankful to be with you today. I'll be picking up with the training component of the presentation after Mernell goes over the science with you, and we'll talk a little bit about how we will implement screening in your specific clinic. So happy to be here with you. I met many of you while I was on site several months ago, but I'm from Dallas, and I'm a nurse and a social worker, so I look forward to speaking to you more later.
Great, thank you both. So what are we in for? So here are the training objectives. We will be reviewing a little bit more about the NPPC program and partnership engagement, reviewing the science of ACEs and toxic stress, orient the providers and staff, that's all of you, to the ACEs screening rationale and protocol development, discuss screening protocol and practice with sample scripts, and depending on time, we'll see how much we can do. And then reviewing education tools, documentation, and additional resources if applicable. So I'd like to share a little bit more about the National Pediatric Practice Community, or NPPC. This is a learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care. Our goals are to engage providers as champions on this issue, provide tools, resources, and training, provide coaching needed to make ACEs screening and the integration of toxic stress a framework, a reality in practice, and to ultimately become a hub for learning about ACEs and toxic stress as they relate to pediatric practice. So this is our vision, that all primary care pediatric medical providers implement universal screening for adverse childhood experiences, ACEs, and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. So here, this is a map of how our community has grown thus far. And as of May of this year, we have 1,000 members in this network since launching 2 years ago. So when I talked about this on the sign-in sheet to hopefully have all of you say that you'd like to join our team, our website, this is it. It's mppcasis.org. So we encourage all of you to be a part of this and get connected with the MPPC virtual network. Sorry about that. We're committed to building a national community of medical providers using an online platform to promote shared learning, disseminate best practices, and cultivate advocates in the medical community. All members have access to our member website, which is a very comprehensive online resource for tools and materials to support screening implementation. And with this, you'll also receive monthly newsletters, announcements for upcoming events, such as webinars, and up-to-date information from the field. We truly view our partnership and value our partnership because this practice has yet to adopt an ACEs screening protocol. So we provide tailored support, training, technical assistance, coaching around all aspects of developing and implementing this protocol. We know that implementing screening can be complex, so we have the expertise and tools that can help your practice implement screening in an effective and a very efficient way. Now that you have some context about this, I'd like for us to build a shared understanding around the science of ACEs. ACEs, or adverse childhood experiences, are potentially traumatic events experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experiences Study, or ACE study, conducted in 1998 by Drs. Vincent Felitti and Robert Anda. It was one of the largest investigations ever conducted to assess connections experiencing adversities in early life and having health outcomes as an adult. So this chart, it's basically saying that the study is the basis for 10 core ACEs, often characterized in 3 categories: abuse, neglect, and household instability. They include physical, emotional, and sexual abuse, physical and emotional neglect, and living in a household where a member has a severe mental illness or substance dependence, or where the child has witnessed violence against their mother, or where there has been separation from a caregiver due to incarceration or shifting parental relationships or divorce. Okay, so many ACEs screening tools screen for additional adversities in addition to the core ACEs. These additional adversities include hardships or significant life events, such as the death or illness of or separation from a caregiver, forms of violence and bullying, and discrimination. These experiences impact a child's health in the same way as the 10 ACEs. So therefore, screening for both ACEs and additional adversities provide a more comprehensive assessment of risk factors for long-term health in a child by combining both the individual and community environment level health items. Okay. In this slide, what we're showing here is that the ACE study told us is ACEs are incredibly common among the population. Over 2/3 of the adult population have experienced at least one ACE. We also have data that shows nearly half of all children today have experienced at least one ACE, and that ACEs accumulates over childhood. We're just briefly going over this data here. This is some state level data for North Carolina. What you see is that nearly 24% of North Carolina children have experienced 2 or more ACEs, and almost a quarter have experienced at least one ACE. We have data that compares what a child in North Carolina who has 1 or more ACE may experience, both good and negative compared to nationally. Of course, we know that while the prevalence of ACEs is common across race, gender, class, and other groups, certain groups are still disproportionately impacted. Those who might be most likely to experience ACEs may certainly find that adversity exacerbated by environmental and structural factors, such as poverty, racism, and discrimination, plays a role. The ACE study and subsequent research has pointed to a dose-response relationship, meaning that more ACEs that someone has, the greater their likelihood of negative health outcomes in adulthood, including the leading cause of death in the US, heart disease, cancer, chronic lung disease, addiction. This slide shows that those with 4 or more ACEs are twice as likely to develop heart disease or cancer and 3 times as likely to have chronic lung disease, 11 times as likely to develop Alzheimer's. So we're talking about ACEs as a potential root cause of some of our most costly diseases. And ACEs doesn't just impact health in adulthood. Many of the health and developmental concerns associated with ACEs also appeared during childhood. Among infants, studies have found associations between ACEs and growth delay, cognitive delay, and sleep disruption. In middle childhood, we find associations between ACEs and asthma, learning difficulties, and behavioral problems. And in adolescence, we find association between ACEs and violence, bullying, teen pregnancy, smoking, weight management. So the question is, how do these early experiences turn into health-damaging ones? What we now understand is that these early experiences act as a stressor on the body, and in doing so, activate our stress response. While this stress response is highly adaptive and generally functions well, when it is activated over and over again, it becomes health damaging. So here, this slide, this shows us the spectrum of the stress response, including positive stress, tolerable stress, and toxic stress. The physiologic response to stress really depends on the nature of the stressors and the availability of buffering and coping strategies. A positive or tolerable stress response is characterized by the return to homeostasis, whereas toxic stress response may induce lasting changes. Toxic stress is characterized by prolonged or frequent activation of the stress response caused by factors such as ACEs that leads to disruption in the way our neuro, endocrine, and immune systems work, leading to negative health impacts. So let's talk about how this impacts the body. And at any point, if you need me to pause for any questions, let me know. I just want to be cautious of your time and just keep this on push while we try to cover quite a bit of information in this time frame. Okay. So some of the neurologic effects can include overactivity and difficulty turning off the stress response, increased fear response, and increased risky behaviors. The immunological effects can include increases in infection and chronic inflammation. The endocrine effects can lead to changes in hormones related to growth, puberty, and metabolism. Research has also found epigenetic effects, which includes changes in the way the DNA is read and expressed, thus increasing risk for diseases such as diabetes and cancer. There can also be substantial individual variability in how adversity and toxic stress shows over the life course. In this image, we see a few different possible trajectories as examples. First, if you're starting from the top, it's possible that an individual who experiences ACEs doesn't present any symptoms and ends up having a healthy life. Moving to the very bottom, we see an individual who experiences toxic stress. We see the disruption, how it manifests as social or cognitive impairment, leading to the adoption of health risk behaviors and leading to disease or disability. These are likely individuals that those of you who are providers already identified through your practice that needs extra support or intervention. Those who have behavioral symptoms are in many ways fortunate because they usually receive some sort of intervention. Because in the middle, what we see is a child who has experienced toxic stress, but perhaps doesn't present the more obvious behavioral symptoms, Perhaps their symptoms are in the form of ADHD or uncontrolled asthma. So perhaps this child has no recognizable symptoms, but as an adult still experiences premature disability or disease. So this actually shows the importance of screenings, because not one person will experience things in the same way. Okay, so we also know that some individuals do and some individuals don't experience toxic stress as a result of negative experiences. So again, there's a lot of individual variability. This right here, the scale, is weighing things, both the good and not so good, that affect a person's health. So we call the positive things protective factors, things that help create a safe and stable foundation for a child. The other end of the scale holds the unfortunate things, the negatives, or risk factors. And ACEs is considered a risk factor. Then there's that fulcrum, the middle part. This is an individual's biology, their genes. Our biological makeup may make us more or less susceptible to stressful experiences. So where the middle is positioned on the scale, which would be different for every person, it affects how much leverage either protective or risk factors have in shaping our life outcomes. So for example, someone who has their scale weighed down by risk factors and is almost more biologically susceptible will be at greater risk for stress-related diseases. All right, so that was quite a bit of information to go over. But I wanted to just go ahead and pause right there before I transition over to Carissa to talk about the ACEs screening and the tool, and see if anyone had any questions about the overview of the ACEs science.
No, I think that was very clear and helpful. Thank you.
Awesome. Great. So I'm just going to go ahead and bring on Carissa. Carissa, they are ready for you.
All right, thank you. Next slide. All right, well, we're going to talk for a few minutes about ACEs screening in general, and then we'll talk a little bit more specifically about screening in your clinic and in your population. Next slide. So as we have implemented ACEs screening at facilities across the country, we have noted some key reasons why ACEs screening is perfectly placed within the primary care setting. It certainly is an ideal setting for talking about health promotion and disease prevention. It's part of what you do every day in seeing children for their well child visits. And we know that in pediatrics, families are much more likely to participate and keep their children coming to the well child visits than we tend to do as adults. We also know that early detection of ACEs and toxic stress can help prevent the negative health outcomes when we implement appropriate protective factors and build resilience in families. And we've noted that the primary care or pediatric caregiver relationship with families tends to be a closer relationship than oftentimes that in adult medicine. And so it's the perfect atmosphere to discuss adverse childhood experiences. When we present the implementation of ACEs screening, we address it in the form of a quality improvement project. And so we apply PI methodology to this project. It's not necessarily a research project, but more of a quality improvement initiative. And so we look at the implementation in the context of a PDCA cycle. And next slide, we'll talk through how this can be used in your clinic as part of a performance improvement activity, can meet requirements for federal grant funding, for PCMH or Joint Commission accreditation. But as you can see, we've already invested significantly in the plan component of this PDCA cycle. We were on site and planned and visited your clinics. While I know you guys aren't on an electronic health record right now, we have worked with your team in other clinics to build the ACEs screening in the EHR. And today we're doing the training. So as you get ready to move into the due cycle of the PDCA, you'll start screening. We'll begin monthly data collection, and I will be participating in monthly coaching calls with both the leadership from Novant and Atrium. At the end of that 6-month cycle, we will continue to do a final data analysis, and then in the ACT cycle component, we'll be working on sustainability and a discussion about whether or not you're ready to spread to other age groups or continue to sustain your efforts as they currently are and redesign the process to be more effective for you. There we go. And now we're going to talk a little bit about ACEs screening protocols and how to effectively initiate them. So we know there are a few key steps in implementing screening. Determining the rationale for screening in your clinic is a key step. It will be kind of the guiding principle as you go forward in planning your workflow, the screening intervals, the population that you want to study. You must identify a tool to be used. Luckily, we've got that component done, and outline a scoring algorithm so that you know at what point you will intervene with which steps, and then developing your education and referral components. So for your clinic and the other clinics that we're working with through Novant, we heard that many of your patients are immigrants and they've come from traumatic situations, that you have a largely uninsured population. Resources are at times limited, so screening could be helpful in determining when and how to use your referrals, and that there can be some mistrust from your population. As providers, we know that you are working actively to create a safe space. You have that lovely room there that you're in to do counseling, and it is very calming and soothing. So it's a wonderful place for patients to come and receive care. We heard from you that you wanted to screen patients that were 5 through 12 years old, and then any new patients that are coming in for school physicals and counseling. So I know this is hard to see, but this is in the packet that you have in front of you. This is the ACE-Q tool that you will be implementing. And you can see on the top in section 1, there are questions with regard to the 10 core ACEs that Murnell went over with you earlier. And in the bottom section, you'll see the 7 items that are more linked with social need or social determinants. And so when implementing this screening tool, it's critically important that we explain to patient families how to fill it out properly. So in CYW terms, we call this tool a de-identified tool, meaning we don't ask what questions specifically or what items specifically the patient family have experienced, but we ask them to fill out the questionnaire using the boxes to the right to put a core or a score that represents the number of items in each section that they've experienced. Now, you may be thinking, why do you do this? And is this a good way to go about screening? We have found that when we have asked the itemized questions, we have a low response rate of yeses, as you can imagine. And I'd like to just remind you all that this screening tool is not for abuse or neglect, but it's really a screening tool for toxic stress or the presence or lack thereof. So in getting an idea of the number of experiences a family has had, you're better able to get a sense of their risk for toxic stress. So the items that you see on the top, again, unless the family fills out a 10 in section 1, which would mean they've experienced every single one of the 4 ACEs, you would not be required to report unless it's a 10 as a mandated reportable. If the family, say, enters a 4 on the top section, we would encourage you to talk to the family, to ask questions about what you can help with that day, but always continue to use your clinical judgment and your vast experience in treating families and screen them as you normally would for neglect and abuse, but not necessarily rely on this tool to help you identify those patients and families that might be experiencing some kind of adversity that would require mandated reporting. Again, we have spoken to our legal team and had countless conversations around the safety and legal issues with regard to mandated reporting, and we have clearly been given advice that unless the score on this top section is a 10, it would not require mandated reporting. It took me a little while to get my head wrapped around this concept. When I started with CYW, I felt some concern that if a family put a 1 in the top section, that 1 might be sexual abuse. And it wasn't until I really thought through the concept that, you know, if a family is not prepared to tell you what they're experiencing, no matter what type of screening tool you give them, they're not going to tell you. And I also needed to rely on my clinical judgment and other signs and symptoms of abuse, and not use this item alone. Next slide. So as we talk a bit about how to implement screening in your clinic, we know that we want to implement screening in a way that is least disruptive as possible to your current workflow. So right now we identified that the best place to hand out the tool would be in the exam room, that lovely exam room with the fireplace that you have that's so cozy. And while it may not be fully completed while in the I said exam room, but I meant waiting room. It would be the nurse or the MA would make sure that it's completed by the time the provider is ready to come into the exam room. The nurse or MA would then hand off to the medical provider and hand the screener to the medical provider to review before walking in the room. Then the doctors and the nurse practitioners and PAs would review the screening questionnaire and decide, based on the score and the presence of symptoms, what follow-up would need to be implemented. And then the clinical staff would work with the families to connect them with referrals or interventions or the in-house counseling that you offer. Next slide. So For a scoring algorithm, we've identified that patients that come into your clinic that are going to be considered low risk would have a score of 0, so no ACEs present, and you would the staff would hand out the what is ACEs patient education material, or some of the other handouts that we will be providing you, like what is toxic stress. For those patients that have a score of 1 to 3 with no symptoms or physical manifestation, we would consider those intermediate risk, and we would provide them patient education on ACEs, toxic stress, and how to build protective factors or resilience. We would then offer additional or consider additional referrals to programs such as CC4C, or your on-site counseling, or Project 658. And as providers, you may decide that you want to see that patient family back in 3 months to assess how they're doing with symptoms, or if they've developed symptoms, and how they've been able to follow up with the linkages you've offered. Patients that are high risk would have a score of 1 to 3 plus symptoms, or a score of 4 or greater. And at that point, the staff would offer not only patient handouts with regard to ACEs and toxic stress and resilience, but you would refer them to your in-house mental health providers and or some specialty services outside the clinic as needed, and would recommend following up with the patient family within 1 to 3 months, depending upon the severity of the symptoms. Next slide. So I'm sure you're wondering, what are these symptoms that you speak of, Carissa? So when we talk about the symptoms associated with toxic stress, we know that they primarily follow the neuroendocrine inflammatory response or cascades that are triggered in the presence of toxic stress. And they can thereby cause symptoms within those systems and across various ages. So we've broken up the symptom checklist, as you can see, based on that same concept. And if you look to the column that says immune inflammatory, the second item where it says asthma, and the third item where it says eczema. I just want to point out that we are certainly not saying that there's a direct correlation between ACEs and asthma. What we're asking you to consider here is, in the family that has a significant ACE score and maybe asthma symptoms that are very difficult to control despite your assessment that the family is being fairly compliant with their medications and inhaler regimen, but the patient family or the patient has frequent or severe asthma exacerbations, we would ask you to consider that. It's very difficult to fit in that box severe or frequent asthma exacerbations. So we just put asthma there, but we're asking you to consider the intent in the context of what we're attempting to have you assess there. So if there are frequent or many symptoms associated with an ACE score, we would ask that you consider following up with the patient more often, or bring them in every 1 to 3 months to assess how they're doing. Next slide. So for your site, you'll be using the paper form to capture the data and have the families, of course, fill out the paper form. And I'm not sure how exactly you'll want to track that internally. Possibly make a copy of the paper form and put it in a folder so that it can be tallied monthly with your scoring. If you make an external or internal referral, I would strongly recommend that you write on the paper form, put an R or some type of indication that the patient has been referred, so that it would be easy to track that as an outcome, which I'll go over in just a moment. Or if the patient family refused, that you just simply write on there refused and capture that as well. So the 4 measures we're asking you to look at and consider as a part of a way to measure the effectiveness of your screening and help to identify and work through any barriers are looking at the percent of patients screened in a given month. So that'll be the number of screening tools you have filled out and completed over the number of new patients or well child visits for patients 5 through 12. The number of patients that have a positive screening over the number of patients that actually filled out the tool would give us the percent positive. And then we'll be looking to see for those that are intermediate or high risk, that's what we're considering positive, how many of those patients were referred to services or may already be in services, so that we could have an idea of the percent that were referred appropriately. And then capturing the number of patients that refuse over the number of patients you've seen again in that given month in your age range will give us an idea of the percentage of patients that are refusing screening, and oftentimes can indicate that we need to go over and talk about how to hand out the questionnaire or consider implementing screening in a more private area or looking at different languages or potential language barriers. Next slide. So I want to take a little bit of a time out, and you can, this will be a good activity to wake you all up again, because I know sometimes training can be a little bit dull. So we're going to have an activity. So I'd like for you guys to pair off and take about 5 minutes, taking turns, just explaining to a family what ACEs are and what toxic stress is.
Okay, yeah. So, the body many different Well, I am very biased to the but much community, there's just one thing that we're not going to share.
All right, it sounds like we had some good discussion there. So let me get a little feedback from everyone. Was it easy to explain yet?
I'm sorry, can you repeat the question?
So far, has it been easy to explain? Are you finding that you're comfortable in explaining what ACEs are and how to talk to families about toxic stress?
Well, it's easy in this room because we all speak English.
That's a good point.
The majority of our patient base is non-English speakers. 90% of our patient demographic is non-English. So I think that's going to be one of the issues we face. I guess my other question right off the bat is, does this come in a Spanish version, the form?
Yes, absolutely. We do have it in Spanish, and we do have all of our patient education materials that we'll be providing you in Spanish as well.
Are there any other languages available?
To date, we don't have other languages, but we would certainly be willing to partner with you if there are key languages that we need to work on to provide translation. Other than Spanish,
Burmese?
Yeah.
Portuguese, Arabic, Russian? Swahili?
What do you think is the second most common language spoken? Well, probably the primary other language.
Portuguese.
Portuguese, okay. So if we can start there, that would be a good place to start. Sounds like, okay. Absolutely, we can do that. We can talk about that and how we can facilitate that. All right, well, let's go to the next slide and we'll talk a little bit about some key concepts that you can say if you're struggling with how to address a patient family, or these are some common phrases that I use that are comfortable for me. So I just try to say things like, you know, ACEs are very common. the more ACEs you have, the greater the chance for toxic stress. ACEs accumulate over time. I had to think about this. Lena quizzed me one time when I was training at CYW and said, can your ACE score go down? And I said, well, sure. And then I thought about it for a moment and I thought, no, it actually can't go down because you cannot unexperience something. So as we get older, we typically do see our ACE score go up. And then ACEs without those things that help protect us and when ACEs occur at key developmental ages, that can increase our risk of toxic stress. And then I think it's just critically important to help families understand the link between toxic stress and illness, both physically and mentally. That when we're really, really stressed, it can make us sick. Next slide. So also in your packet, we have some sample questionnaires about how to fill out the ACE screening tool. And so we would ask that you look over these and find the phrases that are most comfortable for you if you will be handing out the questionnaire. This is a critically important step in implementing the ACEs screening. And so just a couple of these phrases. We have some forms we'd like for you to fill out so your doctor can understand how your child is doing. This one's called the ACE screen. We screen all of our patients ages 5 to 12 so we can understand what they've experienced. When you look at the form, we'll want you just to write the number of events your child has experienced. You don't need to circle any. Just write the number in the box here on the right side of the form for the top section and write the number on the bottom section that you've experienced. So we've sort of timed the explaining the ACEs tool. It takes anywhere from 15 to 30 seconds, depending on how fast you talk or how slow you talk and in what language you're speaking in. So it's a fairly quick thing to explain, but it is important to do it with a certain amount of rigor and methodology. Next slide. So here are some scripts. I had just a southern moment there. Did you hear it? I said scripts. Oh my gosh. Here are some scripts that you might use if you're a provider reviewing a questionnaire. And so to say things like, we ask about ACEs because we care about you and we want to understand what you and your child have been through. So the more we understand about you, the better we can support you. If you have a screen that's positive or has some significant adversities that have been indicated there, you might say something like, because of what your child has experienced, I'm concerned that this may be contributing to some of the problems we've been discussing, like recurrence of bedwetting or frequent asthma exacerbations. And then just following that up, I always like to remind myself and others to sandwich things. And so after you've addressed maybe a concern, to instill a little bit of hope and just make sure that you follow that up with something around resilience or a strengths-based perspective, something the family does well. So to say something like, the earlier we can address these stressors, the faster the body can begin to adjust, excuse me, and heal. Next slide. So before we go to that, I'm going to have you guys turn to each other now. We're going to do another activity where you explain what the ACE questionnaire is and how to fill it out. So I want you all to switch off doing that. We'll take about 5 minutes. And think about being a really ornery patient and give your colleagues a little bit of a hard time. So we could just practice that worst case scenario if that comes up, how we're going to handle that. But I think you'll find explaining how to fill the questionnaire out is a unique thing. It's different from just talking about what ACEs are. So practice that for a few minutes.
Well, I mean, so I don't feel comfortable with I don't want to feel like it's going to be okay. I get the soccer right here.
All right. Did everyone have a chance to practice and give each other a hard time?
Yes.
Good, good. Were there any questions that came up or any insights that you all had?
I think a few people's concerns were just making sure people understand they don't have to circle the specific one that happened, but more just give a total because, yeah, I mean, if you're checking a lot of these and it's like, well, you're going to report me to DSS or, you know,
Right.
So I think that was a concern as well.
Sure. So just making sure that you remind patient families to just fill out the number in the box to the right is key. There will be families that don't understand and that circle items. We do hear about that happening, and that's, you know, I think you should be prepared for that. That's going to happen. Typically, in our experience, families are much less likely to circle the reportables than the non-reportables. We have often found in the context where families do disclose sexual abuse or physical abuse or neglect, that this is something that's occurred in the past, that they've worked through it. And oftentimes they may want to tell you about that, how they got through that. But again, in those instances where you are faced with reporting a concern for a child's safety or welfare, you'll just follow your normal process for doing that within your clinic. And then when you do find, if you have a cluster of forms that are filled out where families are circling the items, just kind of come together as a group and just go over again how to explain the tool, practice that a couple of times. It may be in the way you're explaining it, or it could be if in the way the translation is worded. So, you know, maybe review that with someone that reads or speaks the language that your patient population, so maybe Portuguese. Make sure that the wording is clear, or that your translators or whomever you're using understand how to explain the screening appropriately. Do you guys typically use a language line? I can't quite remember.
Yes.
Yes.
So the majority of our staff, I would say, that is bilingual. We have an interpreter here on most days as well. Spanish. This is all Spanish.
Mm-hmm.
So there's to a language line for all the other languages.
So it would be important too for the language line, and certainly your interpreter who's there on Wednesday, to make sure that they have a chance to read the form, or at least you prep them a little bit about what you're about to try to accomplish, so that
right now.
yeah, that they're not caught off guard. Yeah, very good. All right, let's go back to our case studies, Murnell, and we'll just quickly talk about those and go through them. So I want to talk to you for a moment about think about this in the context of your scoring algorithm. So when you have a patient family that fills out the questionnaire and it's a 2, based on your current scoring algorithm, what risk level would you assign that?
Intermediate.
Very good, intermediate. Now, what if the score was a 2 and the provider noted that the family or the child was experiencing some difficulty in school, was acting out, biting other children, so having some symptoms or physical manifestations with a score of 2 and symptoms, what risk level would you assign? High. Good. Very good. All right. For our next case study, if we have a score of 4, what would that be? Good. And I'm gonna just throw you a little curveball on this one. I know you're all gonna get it right. If you have a score of 10, what are we gonna do?
Report.
Very good. Very good. So
I have
did
a
somebody go, uh-oh? That's what I would say. I would go, but then again, we would report and take care of that appropriately.
There's a question?
So of the 10 items in the top category, the
Yes.
last one seems to be the only one that is not measurable. So if a parent was to ask me, well, how do I know if my child's ever felt unsupported, unloved, or unprotected, what would I say to them?
If they act scared or hide, or kids between 5 and 12 will tell you, you don't love me. Or don't hurt me, please don't hit me, those types of things.
How often would they have to say that for them to mark that one?
I would say use your clinical judgment, but if they're saying it once a week or several times a month, I would consider that to be a yes.
Okay. Thank you.
That's a great question. I've never had that one.
So when we were talking about it earlier during the exercise, I said that that's a question that I really feel like that's a question that when I ask the kids, when I do the AIDS questionnaire with them, is that they oftentimes have a very different response to that than what their parents would say. So I think they need to say, oh no, my child feels loved and supported and da-da-da. And in fact, the children have a very different response to that.
Yeah.
And for this age group, 5 to 12, we're having the parents report on their child's experiences. So this is really an indication of the parents' perception of these things. For children 13 and over, we actually have a teen self-report as well as a parent report. We won't be doing that as part of this pilot, but a lot of folks do see discrepancy between the teen report score and then the parent report of the teen.
And certainly as if there was, thank you, Lena, that's a good point that I forgot to mention. If there is a concern about the child and you're making a referral in-house or even outside, the intent would be there for the next provider to really dig a little bit deeper, do further assessment, do further queries with the patient and the family with regard to how they're feeling and what's going on in the household. So think of this again as a brief or an initial screening tool to identify patients that might need further assessment and intervention. So I think you're absolutely right. When you're working one-on-one with a patient, you can really dig into what the true perception is and what needs to be addressed to help heal that family or promote resilience. Very good. All right. I'm going to have you guys turn to each other and then just practice what you would say if the ACE screen was positive. So pretend to be a provider and talk amongst yourselves and do a role play on what you would say to a family if their score was, say, a 4 on their ACE questionnaire. We'll give you 5 minutes to do that.
Sure, yeah. So because some of these
Luckily, well, I don't know what the price is. I don't know that. It's free with me. I don't know if anybody else was.
Yeah.
That's true.
Yeah, I know.
Okay. Sounds like there's some great discussion going on there. I want to go over a couple of the patient education handouts and then leave some time for questions. So I mentioned these handouts earlier that we'll be providing to you, both in English and Spanish. We have the kind of what are ACEs question, patient handout with the cute little redheaded girl on the top there, which does a good job explaining what adverse childhood experiences are, and gives a little bit of the research on it. It is a front and back. You can also use these just as a talking aid as well. And we have what we call job aids, which will give you talking points for each of the patient handouts that we are going to be providing to you, to make them a little bit easier to use and help you to be successful in implementing the patient education. Then we have the handout on toxic stress, which is a great handout in explaining the connection to mind and body and how sometimes stress can make us sick, both physically and mentally. And then how to reduce the effects of toxic stress. We also have handouts on resilience or protective factors, such as sleep, nutrition, exercise, mindfulness, mental health, good mental health, and supportive relationships within your family. And those are all, I'm sure you have great handouts on sleep and exercise and nutrition, but these are specific to ACEs and sleep and why that's important, and ACEs and nutrition and why that's important. So we hope that you'll use those too and find those helpful in your implementation. All right, next slide. And we're just going to give you some examples from the job aids we have for each of the patient handouts. These are a few things that I usually say. I like to interject humor, if you haven't been able to tell that already. And so I just simply say, when I first heard of ACEs, I didn't understand what they were. And why is it in the medical field we always have to have a fancy name for something? So ACEs are just really difficult or stressful times that you go through in your life. And this handout has some examples of them. Typically, when I am speaking to families about ACEs, I either use the word ACEs or after the first time that we've talked about it, I typically don't use the word adverse over and over when describing it. So I just say experiences or things that we've been through. I find that that helps to provide less of a stigma and also reminds families that ACEs are normal, they're common, and nothing to be ashamed of. We all go through difficult times. But difficult times is sort of my go-to phrase, or difficult experiences. But find what works for you or makes you comfortable. And we'll go to the next slide. So this is the handout on toxic stress. I think it's always helpful to use the phrase, you know, do you think this could be happening in your family? Asking open-ended questions and reinforcing that we want to know this information because we want to help. All right, next slide. So just remember, ACEs are common. If the family's not receptive, I always say, you know, if you don't want to talk about this today, or if they refuse to fill out the questionnaire, to normalize that and say, that's okay. You don't have to fill it out if you're not comfortable. Here's some information about ACEs if you'd like to read that. Maybe you'll feel comfortable filling it out next time. And I often use a little humor there and say, you can read over this handout, or you can make a paper airplane and throw it out on your way out of the building. Just make it okay for patients and families to be receptive or not receptive, and help them to understand that you're willing to meet them where they are. I get a sense that your patient families know that your clinic is a safe place, and you guys sort of embody meeting patient families where they are. That's what you do every day. Don't be afraid to ask what the family is most concerned about or what you can help them with today. All right, next slide. As you all take care of patients and families that are going through all of the experiences they have been through, when I was on site and I heard about the challenging experiences of your patient population and the patients you serve, it did remind me that you all particularly are going to need to practice good self-care and to be aware of how the work that you do, which is a mission. It's missionary work. It's a real act of service. And if you all aren't there to do it, I don't know who will. But so please take care of yourselves. Be and remain connected to the things that bring you hope and fulfillment in your life. Think about your work-life balance. If you have a particularly difficult case in the clinic, maybe a screening tool that just really surprises all of you, debrief about that, talk about it, talk about what you might like to do differently next time, talk about your feelings, and then, you know, always keep in mind that you have an employee assistance program to help you if you need a brief intervention and some stress management or a referral even for additional services. Don't forget to tap into your own resources there. Next slide. Sorry about that. So we've completed our training today. I understand the launch date that we're looking at for your clinic is October 1st. So in the meantime, practice that. You will have access to all the patient education handouts. Maybe have some of those printed and ready for you to use. They do come to you in PDFs in English and in Spanish, and figure out where you want to situate those resources in the clinic and make sure everyone knows where they are. And then, excuse me, if you have further questions, if you'll advance the slide, Murnell. All of our contact information is there, and we welcome your questions and emails. No one ever emails me with questions from clinics, but I'm hopeful that someone will take me up on that someday. So I'd be happy to answer any questions you have via email. And we have a little bit of time right now to answer questions if there are any that have come up.
I think the only concern I have, and I think I mentioned this earlier, so a lot of the families that we're seeing in that age group are newly arriving immigrants from mostly Central America. So we do a ton of school physicals. So a lot of the times we may or may not be their PCP moving forward. So we just kind of see them initially, we do the school physical. And then, you know, we may or may not see them again. So I guess it's a little bit of a concern. I mean, we try to do our best when they're here to address some of their concerns and needs. And I think the other thing, you know, to talk about or resources in general. I sat in on a phone call yesterday about CC4C, but I guess that really targets younger kids, 0 to 5. So are there other, as you've been working here in Charlotte with the Atrium and Yvonne as well, are there other resources for out there that you guys have found out about that maybe we're not aware of? Or that? Yeah. No, that's a great question. So we have found in working throughout the 6 clinics that we're working with in Charlotte, we have heard and seen large referral or resource notebooks in various clinics, and have asked that those be compiled into one list and that those be shared throughout all of the clinics. And there is there is some potential help with that through the Charlotte Resilience Project. And I know there were some contacts that linkages that need to be made a little bit stronger. And we can make sure that that the representative from the Charlotte Resilience Projects has an opportunity to speak to you all and tell you about some of the other
resources that are available in the community.
I have some more information on that as well. So the project leads at both Atrium and Novant are in the midst of, they conducted a listening tour. They met with various social service agencies. They are in the process of compiling a list of agencies who can respond to as screening intervention supports for the various resilience factors that we talked about. So sleep, nutrition, exercise. So really thinking about curating intervention supports using a toxic stress and resilience framework. The hope is that list will be refined by next week, I believe, and that will be shared with all 6 of the practices that are involved in this pilot. So there is definite movement on this front. Both the Charlotte Resilience Project and CC4C are aware of the need for this type of referral coordination, as well as your leads at both Atrium and Novant. So please know that things are in motion. Of course, I think sometimes the coordination between 2 different systems and throughout a community can take longer than anticipated, but we should have a resource list available very soon.
So I've been a part of the trauma work here in Mecklenburg County since its inception, and we were also part of the nonprofit subcommittee, which is now kind of been transitioned to something else as that project has kind of moved forward or kind of changed direction, or whatever the case is. But we run into the same issue of, we have a lot of resources here. We've had a lot of interns do great work on gathering resource information. The problem is, with this population, we seem to be the only resource. And so, that's just the biggest challenge, that we have a capacity issue. As you saw, our clinic is small. We have 1 counseling room up here. So that's just the ongoing challenge, and obviously the lack of funding for individuals that are undocumented.
So I have a few thoughts to share on that, and to follow up with some of the previous comments. So a couple of important things that we have learned about the actual process of screening for ACEs is that families feel that you simply asking about their experiences is an intervention when we've looked at case studies and focus groups. So simply asking about what the family has experienced makes the family feel like, number one, you care about them, and that you have helped them in just asking. We all have a universal need to be known. And so please don't let the fact that maybe you might not see that patient family again, or they may not come back to you after they get their physical. Please consider this the opportunity to plant a seed about toxic stress, and an opportunity to make some referrals or linkages, or help to educate families about toxic stress. And the hope would be that when they go to their next provider, they continue to talk about that. And if we're really successful in Charlotte, eventually everyone in your community will be screening. And so patient families will hear this again and again, no matter where they go. I think we consider it a true honor to partner with both Novant and Atrium and the clinics that work within those 2 systems, because we see the spread and the depth that you have in your communities. And so we feel confident that we can implement ACEs screening pretty globally across your community by just partnering with both of your parent entities, if you will. And I also like to say that, screening for ACEs and talking about ACEs is really a journey. You will rarely have a patient family disclose everything in that first session. They may want to talk to you about it again. They may not, but it is about planting the seed and then helping families to address their concerns as they're ready, with sort of that readiness to change concept in mind. So I just wanted to say that. And are there any other questions? I know we're really at the end of our time, but and I want to be respectful to the important work that you do. Any other thoughts or questions before we wrap up?
And just so everybody knows, our team is always available to you all. As you can see, our contact information is here, both Carissa, Murnell, and myself. If you have any follow-up questions, please feel free to reach out to us. We would be happy to follow up offline.
I think that's it. Thank you so much for your time.
Thank you. Thank you all so much. I hope you have a good week.
All right. Thank you.
Take care.
Thanks,
Bye.
everyone. Take care.
Bye.